Hey everybody, Woman to Woman Collaborative. We are so glad that you have joined us on today. We have got a treat for you. It's Katrina.
And this is Deborah.
So y'all, you know how we talk about hormones all the time, flame on, all the stuff that we've got going on. We have an expert in the house that is going to tell us what we need to do to deal with these hormones. Welcome, Meagan. Thank you so much for being
thank you
here.
for having me. But I want to sing my name. This is Meagan.
Yes. Say your entire name.
Yeah,
Like
yeah.
she's
Your
got a
full
bunch of
government
letters
name.
behind her name. Just
None
tell
of
us
it
your
means
name,
anything.
your letters, all of that. Tell us.
Perfect. So my name's Meagan Del Corral. I'm a double board certified nurse practitioner, and I am certified in bioidentical hormone therapy and peptide therapy. So I help men and women, because men have a lot of hormones too. We talked earlier how men become little bitches as their hormones
she
start
said
to
that,
change. Yeah, it's definitely the truth. So anything someone struggling with menstruation, fertility, menopause, perimenopause, flame on, again, mood instability, sexual dysfunction, and
All the
all
things.
things.
All the
Hot
things.
flashes, night sweats, vaginal dryness, all that fun stuff. I know.
I know.
Yeah.
So let's get into this. So
Yeah.
let's talk. Can we just start with these night sweats and this? Like when you're sitting there, Deborah and I do this all the time. We're sitting there, and then all of a sudden, you just got to bring a fan out because your whole body is on
Yeah,
fire.
you're like, I have
Right.
been lit from the inside
From
out.
the inside. Hey,
Yeah.
I'm angry.
Yes.
I'm angry.
Anything you
I'm
can share
angry.
on that.
Flame
Yes.
on, flame on.
Flame
I
on.
just like that term. So it's called a hot flash, and scientifically it's called a vasomotor symptom. So essentially, as estrogen starts to decline, and progesterone. So estrogen and progesterone are like our two sister hormones. And after the age of 35, progesterone starts to decline. And we think of progesterone, it's highest when women are pregnant. So I would say pro-gestation, pro-life. And symptoms of low progesterone can be more specifically night sweats, not as much during the day, insomnia, so sleep disturbances, and mood instability. So the flame on, I'm more irritable,
Yeah.
less happy, kind of want to hurt everybody.
Yes.
So, yeah.
Yes.
When estrogen starts to decline, then we have more of these vasomotor symptoms, and that's really that heat intensity, hot flashes. I could, sit in my cold plunge forever and never come out.
Yes.
Kind of feeling
I
for
feel
sure.
it every day.
So is it true or is it a myth that the hot flash is sort of a mini stroke?
I don't know if it's a constriction of blood vessels, which is the same thing again. So vaso means tone of blood vessels, and motor is in action. So it's
Okay.
true. And a stroke is the same thing. It's a lack of blood flow to a part of the body, whether that's the brain, the heart, the gut, wherever the infarction is happening. So I guess in some ways it could be considered that.
Yeah.
But it is, if you've ever experienced, which I've had many,
You've
is,
had hot flashes?
Oh my gosh.
Oh my
yes.
God, you look
Wow.
too young.
Yeah,
Oh no,
exactly.
no. I
Yeah.
started going. So it's a different story for another
Oh.
day. But I started going through menopause when I was 29, so 10 years
Oh,
ago.
wow.
And I remember thinking I was dying. So I was like, why?
Yeah,
Yes.
because we don't talk about
We
this.
don't talk
Katrina
about
and I
it.
have talked about this before. That growing up, I thought the only thing I was going to be dealing with in the latter part of my life when menopause set in was I was going to get hot occasionally
Right.
Sure.
and
Stop period.
stop period.
Yes, and
Yeah.
I was
That
looking
was
forward
it.
to
You're like,
that.
yeah,
I
that
feel
sounds
like
good.
I was
Yeah.
cheated.
I was
Like my
bamboozled.
mother did not prepare me,
I was
but I'm
like-
not as mad anymore because I don't think she knew.
I don't think
She
so.
had
Yeah.
no clue.
Right.
I think there is a lot of misinformation and a lot of but it's normal. And it is true. Like
Yeah.
I always say, ovarian failure or menopause happens to everybody.
Yeah.
No one is
Right.
going to outrun it, whether you have
True.
it surgically, chemically, or chronologically through
Right.
aging. But that doesn't mean it has to suck.
Right.
Right? And
It
it does.
doesn't.
And it sucks. Yeah.
So let's talk about this, because so many times you go to the doctor, you say you're going through all these symptoms, and then the first thing they say is, like you mentioned earlier today on the panel, that they try to throw medicines that are like antidepressants at
Yeah,
you. Like,
yeah.
what is, where should you really start? Like, a lot of women don't want to start with medicine, but
Sure.
where do you start?
So I think the first thing is, I would say, test and don't guess. So get your blood drawn.
Okay.
And there are more advanced hormone testing out there. People do urinary tests, saliva tests, and those are all fine, and we use those as well. But by and far, you get away with a lot with blood work.
Yeah.
So look at what your ovarian function is. We can see, again, biochemically through specific hormone markers, so one being follicular stimulating hormone. This is a message from your brain to your ovaries to make estrogen. So it's like a man with a microphone. And what happens is, as you transition through menopause, that follicular stimulating hormone, or FSH, gets higher. And that's because the brain is yelling louder to your ovaries, make estrogen. Your ovaries are like, no way, we're done. So that gets higher, estrogen goes down. So we can see that, and we can be like, okay, listen, we see some changes going on. And also, you know, we have to remember we're talking specifically about reproductive hormones, but we also want to look at your thyroid, which is a hormone. We want to look at your insulin, which is a hormone made by your pancreas, because all of these things play a huge role in how we look, feel, and perform every single day.
Yes, absolutely. You said something on the panel today. You mentioned that you do not have to have a cessation of period for 12 months for it to be indicative of that.
Yes.
And I thought that was it.
I did too.
Because
we talk about this all the time.
All
I'm
the
like,
time.
I know I'm in menopause.
and then it was starting over. So
and then
what
it
is
starts
happening?
over.
Yeah, so the criteria for menopause, technically, it's one of two things: a follicular stimulating hormone of 25 or greater,
Okay.
and or cessation of period for 12 consecutive months.
Okay.
I will tell you, 90% of my patients who I treat as menopausal women have a period maybe once every 9 months. Like I always call it, you get the dwindles.
Yes.
Okay.
And
That's
the dwindles start to happen,
Yeah,
and
the dwindles.
and why would you wait to be
why
why do you
would you?
hold on and then you're like, okay, now we'll give you hormones? Why would you do that?
Right.
Yeah.
Right.
It happens.
It's like if you have one, flat tire, why would you slash all
Why
four?
would you
Right.
wait?
That is so
And I've got to
true.
ask you,
Do it,
because I
Deborah.
have a family history of breast cancer on my
Sure.
father's side.
Sure.
But my doctor is very hesitant about prescribing any HRTs to me
Sure.
because of the potential risk of developing breast cancer.
Sure.
Now, I've not had any abnormal
Yeah.
mammograms or anything like that.
Sure.
So what are your thoughts? It's just, I mean,
Sure.
Right.
and it's just your opinion.
Yeah.
Yeah,
So,
it's okay. Yeah.
this is,
I'm
this
not
is-
treating her.
Right,
She's not
right,
saying
yes,
consent.
exactly.
No, so where the guidelines came from, and when we look at estrogen receptor related breast cancer specifically, the correlation to bioidentical, the appropriate dose of estrogen therapy is actually very little to none. So the Women's
Okay.
Health Initiative, which was the largest and only study that we have to reference when it comes to hormone therapy, only used what are called synthetic hormones that were derived from the urine of horses, so equine urine. Yeah, this is great.
What in the
It's
world?
really
What?
delicious.
Okay, so for
This is
anybody,
mind
so I'm
blowing
hearing
right
you
now.
say that the study was done on horses,
Right.
and we are still dealing with it.
And we
Today.
still use that as a standard of care.
This is why
Did
you
you
said
hear
it was
this?
horrible.
It's a
earlier.
horrible study.
This
There's a
is
lot of
yes,
faults. There's a lot of
yes.
faults.
Yes.
Yes.
And again, I think there are a lot of women who didn't get hormones. What I always say to patients is, okay, if we're worried about a family history, let's do the number one thing, which is early detection. So you said you're compliant with mammograms.
Yes.
So if you have normal mammograms, you're otherwise healthy. We don't have a personal history of breast cancer. There's no reason why you can't have, again, a appropriate physiologic normal dose of estrogen.
Okay.
And that's really important because I always tell my patients, I am not trying to make you back to where you were when you were fertile, nor do you want to be. 'Cause
No.
do you want to
No,
start menstruating
no,
again all the
no,
time and doing it? No,
no,
we just
no.
want you to not sweat anymore,
Yes.
Yes.
not be so flamed on.
Flame
Yes.
on.
And not be so, not have to. We want some elasticity back.
Yeah, we want our face to feel a little bit. We
Oh,
want to get a little more
yes.
bang for our,
Yeah.
cosmetic bucks.
Exactly.
Yeah, 100%.
Yes.
And it doesn't take much.
Yeah.
So when we're looking at blood work, menopausal women, if I want to look for an estradiol, which is a blood level we look at, I'm looking for maybe somewhere 50 to 80,
Okay.
which a menstruating woman, to put in the context, her normal estradiol level is somewhere 100 to 250.
Okay.
So,
Yeah.
very small amounts of hormones can help you feel so much better.
Let me
This is
ask you this.
excellent.
You've talked about blood work. Now, is this like when you go to your regular doctor blood
Sure.
work, or is this special blood work? Or?
So it can be either.
Okay.
It depends on your primary care. So in my practice, our consultation blood work is totally comprehensive because I want to know everything. I want to know what your thyroid is, I want to know what your cholesterol is, I want to know what your hormones are. I want to look at your what your pancreas is doing, your insulin, your hemoglobin A1C, and all things that you can ask your primary care to
Okay.
run. You just have to probably be pretty specific because they're just not I mean, to be honest, what they'll say is, well, I don't know what to do with all that. And that's okay. But it is helpful to have the knowledge.
Absolutely.
Yes,
Absolutely.
yes.
And I love it that you are a telehealth practice. Okay. I'm going to edit that.
You're fine.
But that you're a telehealth practice for anyone that
Yeah.
may be remote, that wants to visit
Sure.
with you. So could you share a little bit about that?
Yeah, so Vital Medical, we are a completely telehealth practice in all 50 states. So there is some limitation. I can't do a vaginal exam.
Right.
So I do always recommend my patients still have a local
Oh,
provider.
absolutely.
Someone has to look,
Yeah.
feel, and listen, right? All those things we don't have. But we're able to do a lot. Nowadays it's gotten better. So we can see everybody virtually, compensate for time zone change. Everything is, compliant, and I've been in this business a long time. We always say, like, before telehealth was cool. And
Yeah, because during
Yeah.
COVID it got to be a thing.
it got to be a thing. Yeah.
But you were already doing it.
Yeah, we had like entered in. First it was a phone call, and then we're like, no, we probably should look at people. Yeah, video, and now it's there's monetizing. It's a business, right? Yeah, so there's
right.
always something to support us. And all of our hormones ship to our patients directly to their front door. They don't have to pick it up at their local pharmacy. There's a lot of, we decrease the barrier to entry as much as possible, and everybody receives a prescribed custom tailored plan. So your hormone treatment would look very different from hers, and as it should. And because you have specific goals and you have specific biomarkers, and you have a history, she has a different history, right? And so we take all that into account when we're treating our patients.
Excellent.
Yes,
Excellent.
this has been excellent. So tell us again the name of your company,
Yes.
how to reach you,
Yeah,
so
of
women
course.
can get right to you.
Absolutely, and thank you both for having me.
Absolutely.
Say thank you. This has been so
Exciting.
fun.
I
Yeah.
love it.
And we worked really hard to not be shiny.
Oh, we
Right.
tried.
Right.
Right, y'all. It's
Show
100
it.
degrees day.
You
I
look
know.
beautiful.
I know.
You look
Yes.
We're
beautiful.
trying. We're trying.
Yes.
So it's VitalMed, VIDALMED.com is our website, at VitalMed on Instagram and Facebook. And our office phone number is 513-966-4464. Looking at my coordinator, make sure I got that right, because
That's
I
right. Got to.
don't know. Yeah.
Well, thank you so much.
No,
This
thank
has
you for
been
having me.
so
I
good.
appreciate it.
Yes,
I
we so
love it.
appreciate that. Woman to Woman Collaborative, guys. This was the topic that we have wanted to know so much about, and Meagan
No
has
more
fooled
flame
us.
on. We're gonna flame on.
We're gonna try not to flame on anymore. I'm going to get my hormones.
Exactly.
We'll see you next time.
exactly.
Thanks, everybody.
Bye.